Let's go on to heart failure. Heart failure is kind of a sister disease to angina treatment because we use many of the similar kinds of treatments. Now, how we treat heart failure is a little bit different. We can use inotropes, and those inotropes include cardiac glycosides, beta agonists, and PDE inhibitors. We can use vasodilators like the PDE inhibitors, nitrates, and the loop diuretics, and we can use classic cardiac remodeling agents like loop diuretics, ACE inhibitors, ARBs, spironolactone, and the new steroid. Let's move on to the cardiac glycosides. The prototypical agent in this drug class is digoxin. There are other cardiac glycosides out there. Digoxin is derived from the digitalis plant. It's also called the foxglove plant. It inhibits the sodium-potassium ATPase pump. This results in an increase in sodium levels in the cell. This results in less excretion of calcium through the cotransporter and higher levels of calcium within the cell. With higher levels of calcium within the cell, you have increased calcium release from the sarcoplasmic reticulum. Now, the strength of contraction is going to be increased because you have more calcium. So strength of contraction is proportional to intracellular calcium. Interestingly enough, you will also have a reduction in heart rate. Digoxin reduces symptoms of heart failure, and it reduces hospitalization due to heart failure, but it does not prolong life. This is based on major studies looking at this particular agent in heart failure. Dosing, it has a very narrow therapeutic window, so we actually have to monitor digoxin levels in patients. The drug can accumulate in the body, so that's why we monitor the serum levels. You can get digoxin toxicity. This beautiful picture here is just a picture of the foxglove plant, which actually grows as a weed where I grew up. Interactions of digoxin, it interacts with quinidine, which is also derived from a similar plant. The toxicity is increased with low potassium levels and low magnesium levels and high serum calcium levels. So when you're going to administer digoxin to a patient, make sure you check the electrolytes. Toxicity can also result in arrhythmia, nausea, vomiting, and diarrhea. The arrhythmia is occurring due to intracellular calcium overload. How do you treat it? Number one, correct your electrolyte abnormality. Number two, we can give antiarrhythmic drugs. Lidocaine, phenytoin, and propranolol are some of the agents that we use. There's actually a product called Digibind, which is fragments of binding material that bind the product or bind the digoxin in the serum and brings it out of activity. We do not use antiarrhythmics in patients who have heart block because the antiarrhythmics are not going to help them. Consider pacemaker therapy. Now, at one time, we used to use a ton of digoxin, and at that time, we used to see a lot of patients coming in with significant heart block from digoxin toxicity. We used to get maybe 1 or 2 a night in our hospital, and so we used to use temporary pacing quite a bit. With the reduction of use of digoxin over the years, we're doing less and less of this. Let's move on to beta-1 agonists. These drugs are mostly used in the intensive care unit or in the coronary care unit. These are IV drugs, dobutamine and dopamine. They are not appropriate for chronic long-term failure because these drugs are subject to tolerance. They can also cause arrhythmia, so we don't like to use them if we don't have to. There's no oral version of these medications, so taking a pill of this particular drug is just not an option. Milrinone is a phosphodiesterase inhibitor that is now being used in heart failure. Once again, this is an ICU or CCU drug. It has positive inotropic effects because it releases cyclic AMP by inhibiting the PDE3 molecule. This increases intracellular levels of calcium, and by increasing intracellular levels of calcium, you have an increased strength of contraction or inotropy. Now remember, the word inotropy comes from the Greek god Inos, who is the god of strength. So whenever you hear inotropy or Inos, that's strength of contraction. There is a vasodilatory action that milrinone has as well, and we think that it's having a direct action right at the level of vascular smooth muscle. It can be arrhythmogenic, and so we tend to avoid it in long-term chronic heart failure patients. It can actually increase mortality in chronic heart failure, so it's really not a great choice in those patients.